Thank you for coming, you couple of people. I'm very excited. This is an extremely interesting new concept in scar rehabilitation. Since 2009, when Jill Uebelhoer first started doing this work, we can now take contracted and restrictive scars to a different level of rehabilitation that we couldn't do before 2008. And it's very exciting work. I'm going to show the work that I did in the Navy using the CO2. We had two of these UltraPulse CO2s. They were workhorses for us. By far was the best laser that we used for scar rehabilitation in what I'm going to be talking about. I do want to say that the Navy, of course, does not endorse anything that I say or any company, but that's just important. So anyway, so let's talk about the injury first. It's a very unique injury. When you're doing this technique, our protocol calls for a very high energy, but an extremely low density and a very quick pulsed laser. And that's why we use the UltraPulse, because it has a pulse width less than 100 milliseconds, which is less than the thermal relaxation time of water and collagen, and it also has a beam size that's under 400 microns. We know that between 400 and 500 microns, when you drill a hole at that width, you're going to get scarring rather than this type of healing that we see with this. And so we're doing 120 micron holes with very little collateral thermal damage. You see the ablative channel and then a little bit of collateral thermal damage, all being well under 400 microns. And that is so important, because that's why what we believe is why these scars heal so well, is because they're not going through the typical scarring process. Rather, maybe endothelial cells can reach across at that small width and can there's enough oxygen there to create this healing mechanism that rejuvenates or remodels at least, and probably regenerates skin. So in typical cosmetic settings, we're using these multiple passes of higher density and lower energy. So you go down through the epidermis, maybe into the papillary dermis, or sometimes just into the epidermis on your passes. And you're doing multiple passes, higher density, and of course, with the CO2, the fractionated CO2, these are Jill Uebelhoer's photos, but you can get great improvements with those techniques. But what I'm talking about for rehabilitation of scars is a much different profile, and you're talking about using very thin pulses, like I said before, less than 120 micron, or about 120 microns, and big gaps in between each pulse. So the density is very low. Does everybody understand what I mean by low density here compared to the other? Also, we're going very deep into the skin. We're actually matching the energy with the scar. So if the scar is 3 millimeters deep, we want to turn it up to an energy that's going to get us close to 3 millimeters. We haven't done any going into the fat on purpose, at least, and we find that you don't need to. You don't need to do the full depth of the scar, but we try to get as deep as we can within the scar based on the energy. So here's the procedure in action. You can see the stamping technique is stamping a handpiece is so critical when we're moving around through these scars. It's very difficult to do it with a different type of handpiece. And you take this patient, one of our early patients who had a scar a blast injury to his hand, lost one of his fingers, had 14 surgeries here, was about to have another surgery to try and release his hand some more. Here he's trying to create a fist with his hand as hard as he can, and you can see the blanching in the skin. And that's turned out to be one of our signs for where to treat. We look for where there's blanching, where there's the most tension in the scar. And in this case, you can see straight up through his palm, we treated that whole area with, again, a single pass, very low density, but very high energy. And not as when you think about doing full face resurfacing, we're putting pulse next to pulse next to pulse. There's a little bit of gap in between pulses. We're trying as hard as we can not to get an overlap at all of these pulses. And sure enough, after 2 treatments, he was able to bring his thumb across his hand, able to move his fingers better. He was able to reach in his pocket and get things out of his pocket, which he couldn't do before. A couple more treatments, and we got him to this point, which is unbelievable. Now, not every patient goes to this point, but a lot of patients do, especially in hand injuries. We've been able to get a ton of improvement in range of motion in the hands. It's very exciting. Here's another burn scar on one of our wounded warriors, and you can see there's very little change from the pre-treatment to the post-treatment. His range of motion only increased about 13 degrees, but that amount of improvement reduces pain and also increases the quality of life, and that's what's been so exciting. Is this gentle, small improvement with very conservative settings, very low risk treatment can get you significant improvement in quality of life. Now here's, we were concerned we were going too deep on some scars because some scars seemed atrophic. Then when we would do high energy or high frequency ultrasounds to try and determine the depth of the skin, we realized that a lot of these scars were over 3 millimeters that we thought were less. But what we started doing even more was matching the scar depth with the energy, and I think that's very important. So Lumenis came up with we asked for more energy. They gave us this new module, the Scar FX, which allowed us to go even deeper than we were doing before. Before we were doing about 2.6 millimeters, and now we could get up to 4 or more, 6 even millimeters into the skin. And this is one of the first patients I treated. He was a guy who had a blast injury that resulted in inability for him to turn his head all the way to the left. He could turn to the right, but when he turned to the left, it pulled down on his cheek and caused a lot of pain. And he had been in rehabilitation for, I believe, over a year by the time we saw him, and was at a plateau point. You can see on this picture, he is turning to the left as far as he can. His nose comes in front of his shoulder. He can't get it all the way over to the side of his shoulder because of the pull and the pain and just the tightness of that scar. We treated him twice, and he was able to bring his nose all the way to his shoulder. He still had tightness. He still had the scar, but he had a dramatic improvement in his range of motion, which was very significant for him, and is a classic example. Here's a nice video of it. Here he is before the treatment, turning to the right, no problem. He turns to the left, and he pulls down on his cheek. He can't turn all the way to the left, pulls down on his lip, I mean. Now here he is post-treatment, post 2 treatments, and essentially almost full range of motion. Dramatically improved there for this wounded warrior. Just to show you a little bit of a graphic that Ray Choi put together for me, you can see the difference. There's a significant difference in that range of motion, the angle that he's able to turn. And this is not our best case. This is one of hundreds of cases where we see this improvement over and over again. I show this case too because this is a big arm. He's got a big burn across his body, down his arm, and we treated him early. You can see his tracheotomy scar is still fresh and red. And we went ahead and treated him very, very conservative settings and immediately started to see improvements in his range of motion. You can see here he's trying to raise his arm. Again, I don't know if you can see on the screen the blanching of the skin as he tries to raise his arm and can't do it. We treated him 1 time. He had improvement. We then treated him again 6 times or more, and he was able to raise his arm essentially normally. Which was fantastic. So not just fingers, not just the neck, but large limbs too. And not only scars, but also scarring processes. We went ahead and saw a patient. I saw a patient in our clinic that had localized scleroderma. And she was having extreme pain when she'd walk. She couldn't dorsiflex her left foot. You can see she's trying to dorsiflex her left foot right here. It won't go down, and also it was painful for her to walk. We had treated her for over a year with aggressive treatments, including UVA1, methotrexate, prednisone. She had plateaued. We went ahead and treated her once again. On that first treatment, she saw some improvement that improved her pain. and that was enough for her to come back. We treated her a couple more times, and we published this in the archives, or now JAMA Dermatology, where she was able to get essentially full range of motion. She could still feel some of the tightness, but the pain was gone when she was walking. She could now ambulate normally, and she could essentially dorsiflex her foot at the same as she could with the other side, on the right side. So what's our outcomes that we're looking for? The biggest improvement that we're so excited about is range of motion. We treat every scar that we see with this protocol, and a lot of them get some sort of increased range of motion, and you've seen some of these dramatic cases. Reduced pain is very frequent. We get a lot of patients who have pain in these scars, pain as they walk, pain as they do their activities of daily living, and the pain is often reduced. At worst, we get improved pliability. In almost all of our scars have had at least pliability improvement. And then finally, we noticed is that as we treated these scars that had ulcers with them, those ulcers would heal. Ulcers that had been there for years, or at least months at times. Others that had been there for over 10 years, come and gone in these scars. And we just noticed that these ulcers would go away. And we started then searching for ulcers and treating them, and they would improve. Let's talk about that briefly. We published that as well in the archives. The two types of ulcers that we were looking for were the ones that were these tension erosions and ulcerations over contracted scars, and then the pressure ulcers over flaps and grafts, where patients had prosthetics that were keeping ulcers from healing. You'll see this is one of the early cases. This is a guy, we were just trying to improve his range of motion of his leg, and he had a little bit of an erosion there on the side of his leg as well. And as we treated him, his range of motion improved. Is he perfect? No, but you can see a little bit of improvement in his range of motion. There was a dramatic improvement for him in terms of his quality of life. Plus, he said, this erosion that they've been trying to treat for months went away as well. So we started trying to treat other ulcers like this one. This is a classic ulcer right over the area of most tension in this gentleman who had many operations, Z-plasties, to try and improve this. And we lased him with this high-energy, low-density ablative fractional laser. And in a couple of weeks, he looked like this. And after 3 or 4 treatments, he was at this point, which was a dramatic difference. And our wound care clinic was very surprised. It was initially thought to be just coincidental, but since then we've treated many scars and ulcers like this, and they respond really well. Here's another patient that we treated back in 2001, 2002 for his tattooing of his face from a blast injury. Then he came back years later with to get some more treatment of the face, and we noticed that he still had this ulceration on his limb that had been injured in the bomb blast. We went ahead and treated that spot again. This is now 2010, and we had last treated him in about 2003 or so. So you're talking about 7 years of dealing with this erosion coming back and forth and back and forth. We treated him 2 weeks later. It had healed up. 6 months later, it was still healed. We treated him a couple more times, and he continued to have improvements. We have seen in these cases the longevity of some of these ulcers not lasting as long as the longevity of the functional improvement. But it is remarkable to show that that's an option. Finally, treating over these graft sites where there's a lot of pressure against prosthetics has been incredible for us as well. Using, again, the same protocol of this high-energy, low-density fractional laser treating the scar and the wound bed. And you can see the improvement in this one as well. That makes a big difference for somebody who's walking on a leg on a prosthetic, where they can now use that prosthetic and be ambulatory compared to, or for much more of the day, compared to when they have the ulcer and they have to keep taking it off and keep changing those dressings. It's a huge difference. I also want to show you these ulcers. This is Dr. Chad Hivner, Air Force dermatologist, does a lot of the same work. And he used just the active FX side of the UltraPulse. And just by debriding it every 2 to 3 weeks for 6 months, he was able to get this improvement. Now, this is not perfect, but this patient for years has had no improvement was in pressure pressure chamber, altitude chamber treatments, and heavy wound care, and just could not get this to improve. And he was able to get it to this point, which was better than years before. And here's the other leg that had a similar ulceration. She had a sclerotic disease that was causing this, and you can see that tendon there as well. Again, improved with multiple treatments with active FX. Finally, who else can benefit from this? It's not just military. Every person who has a scar, especially who has a burn scar, which there's millions in the U.S. that could benefit from this. And here's the second blast that went off in my hometown of Boston, Massachusetts, at the marathon last year. And this was a patient that I was fortunate enough from that blast to collaborate with Jeff Dover there in Boston, and we were able to treat her scars on her legs. And after a couple of treatments, she had some significant improvement and had the positive smile sign that we see so often from these patients after we've treated them. Because a lot of times they reach this plateau and plastic surgery has no more options for them. And now we have this option. It's an incredible thing to offer patients. We've also, in the military, done a lot of missions work around Southeast Asia, South America, Africa, and here's a patient in Vietnam where we treated very basic settings, just a couple of areas. We didn't treat her whole body, just treated a couple of the areas that showed the most tension. And sure enough, the next day, the child's able to sit, which she hasn't done since the burn injury by herself. After another treatment, she was able to walk a little bit. Again, not perfect, but more improvement than we've been able to get before we had this type of technology. And here's Dr. Shoemaker, who's my partner at the Navy. Now he runs the the dermatology department there. He's done a lot of this work, and he was in Vietnam then the following year, treating more of these patients. He treated this lady with both Z-plasties and the laser treatment all in one treatment day, and was able to get dramatic improvement in that scar as well. And that's a great point to show that a couple of things. First of all, this laser treatment is not a monotherapy. This is to be used with everything that we're already doing for scars. It's not to take away what the plastic surgeons are doing, except maybe require less revisions to these scars. And the second thing is this is a treatment that you can do one time on a patient and have the confidence that there's going to be a very, very, very low risk to that patient. And that's why we can go into a place, these Hanoi and other areas that we've gone into in Vietnam and Indonesia, and treat somebody and leave and have the confidence that we're not hurting them. We're not running the risk of them getting infected or other problems like so many of our other procedures in medicine do. So it's really exciting. So our protocol, again, high energy, short pulse, narrow beam, low density, single pass. Where do you get that? It's in the UltraPulse, because it's got that very high peak power that it can produce to fire the beam quicker than a millisecond and give you this unique injury. Again, I can't emphasize that enough. And just keep it unique. You don't want to change this, because we've treated hundreds and hundreds of patients. After you've treated 1,000 patients, then start playing with the settings, because I see so many patients that have been re-injured and have devastating results when you increase the energy and increase the density of these treatments. So keep the density low and the energy high. And here's really quickly, I don't know how much more time I have, but here's an example treatment. Here's a patient who's had this scar since he was a child. He's pointing out the areas where it hurts the most, the tension of the scar. As he turns his arm, we can see the pull on the skin. We can also see the blanching of the skin. It's nice if you have a goniometer to use it pre-treatment, because it really can help you objectively see the difference. But here we are, lasing then. We do a small area. Again, we're not trying to make these perfect right next to each other. We're just treating a small area, then we cover it with Kenalog afterward. And then we go on to another area and slowly treat through that vector of where the most restriction is. And not trying to treat the whole scar at once, although sometimes we do. Usually we're just treating small areas. In summary, for rehabilitation, there's just nothing like the UltraPulse for us has been a workhorse for all these wounded warriors. It has a predictable benefit in restrictive cutaneous scars. Really, when I see patients come in and I see them move their arm and I can see where the restriction is, you know that they're going to get some sort of result, some sort of improvement, especially in range of motion. Then we have seen positive responses in all phases of scars, whether it's an early scar, an old scar. They all should be treated. Adverse outcomes can be avoided. Adverse outcomes can be absolutely terrible if you use these settings wrong, because it creates it's such a deep injury. You can get a full thickness new scar. But if you just follow this protocol and use it properly, the risks are extremely low. We've had a couple of infections, maybe, since 2009. It's remarkable with all the number of treatments we've done, and yet we get an improvement. Finally, we don't know which ulcers are going to respond, but certainly this new treatment of ulcers is really exciting. The bottom line is you get a positive impact with a very low risk. There's a lot of things that are going to happen in the future with this. We're delivering medications. I think that's going to be one of the most exciting things. We're delivering medications to treat cancer, to treat other medical issues. But the fact that we can rehabilitate these scars like we never could before 2008 is really exciting. And there's no question, we use a lot of different lasers, but this laser's been our workhorse, and it gives us the optimal result, and it makes sense to us that because we're using such a quick pulse, such a very narrow beam diameter, we're able to get these results. So anyway, thank you for being here, and it's always exciting to talk about this. All right, yes, yeah, questions, please.
What kind of anesthesia?
So what kind of anesthesia do we use is the question. We've tried tumescence, we've tried topical, we've tried general anesthesia, conscious sedation. The vast majority of our treatments are done with topical anesthesia and maybe some ice roller or bulk ice cooling. And some patients, because we're only treating a small area or a quick strip of area, they prefer just to have ice on there, and then we'll laze and ice and laze and ice. There are some patients, for all kinds of reasons, some patients who have too much scar where we need to give them more anesthesia. And usually that means conscious sedation of some sort. And usually that's because of PTSD issues as well. But we've had plenty of big, long scars where we've treated a patient for 30 more minutes, and all they needed was topical to get through it. So a lot of times the scars are an anesthetic too. Let me get this question and I'll come back to you. Yeah. Yeah, right. So the question is, where in the ulcer do we treat essentially? And we do. We start with the scar with our high settings, and then we do the rim of the ulcer, and then we do much lower settings, but still relatively high energy, low density, right through the bed of the scar. And again, we're not trying to make them perfectly right next to each other. We have little gaps in between them so that we're making sure we don't overlap any of those pulses. But yes, we go right through the middle. Yeah, go ahead.
Question just to follow up. If you go to the ulcer, don't you afraid of splatter of blood and tissue?
With the CO2, you don't get a lot of splatter because of the coagulation that happens with the CO2. Yeah. Sure. Yeah, we don't. No, splatter of blood has not been a problem. Sometimes the scars don't barely bleed. Right. I was just saying that. Yeah. Sometimes anyway. But over an ulcer, yeah. I mean, we'll see bleeding. But again, I'm not doing multiple pulses. I pulse, and we're done. Yeah. Single pass is very important. Yeah. Go ahead. Give me one. Go ahead.
Treating hypertrophic scars or keloids on the chest.
Yeah. Yes. Hypertrophic scars. Keloids are very different. We are treating those. We're using a little bit different protocols. We're adding we're sometimes shaving them, sometimes CO2 ablative resurfacing on them, adding.
Just a deep FX.
But just deep FX over a keloid, I've not had any success with. Yeah. Over a true keloid. Over hypertrophic scars, absolutely.
So you would use the scar FX over keloid.
Even scar FX on a keloid is not in my hands has not been successful, but with other modalities that we've been able to treat keloids. But
Say low density or about 5%.
nothing for me, nothing more than 5%. There are some folks like Chad Hivner. He's done thousands of these cases as well. You know, he uses 10% at times. Jill Uebel uses 10% at times. And I think that's fine. When you know how these scars are going to respond, I think it's a great option. For us, when you have a patient has a prosthetic, and we've always felt we don't want any risk, because if you injure that prosthetic, if they get an infection, they end up having to cut more of the bone back, and that it's almost a logarithmic change in how their rehabilitation is going to be with a new prosthetic. They got to get a whole new prosthetic, learn how to walk again, just with that little difference in bone, and that's what happens. So. Ever since the beginning, we've just been very, very careful with that. Yeah. Okay, yeah, thank you for coming. Yes, what was your question?
Have you had luck putting topical products on atrophic scars after you start, either that's in sculpture or Ristylane, Perlane, you go through down the channels, that's what
Right. I have not. I've been doing mainly Kenalog, Dr. Shoemaker and I, but Jill Uebel's done some of that, putting Sculptra down the channels, and there's no question that's the future. That's going to be very, very exciting. And I think these channels, the way we ablate it, again, because it's such a quick ablation, you don't get much char at all. And if you extend that pulse width out at all, a little bit over a millisecond, you start getting more char. So without any char and very little collateral thermal damage, we're able to, and no bleeding. A lot less bleeding than other devices. You know, I use the erbium a lot too, and that you just get a lot of bleeding, and so you're able to put those down the channels.
when you're witnessing the serum and the
Okay, thank you.
edema going through, just what the time frame is.
Yeah,
The window, the topicals on,
yeah,
everything's coming up, the pants were brand new.
yeah. You're like a plant. Do you work for the company or something? It's like I planted you in the audience. It's extremely exciting point. We really think that it's 2 minutes, and that's why I showed on my video. We'll laze a little bit, and then boom, we'll put the Kenalog down the channels. We really think that 2 minute window is optimum. That's a great question. The question for the other three people was, I don't know if you heard it, was just about when do you put things down those channels. And I do a lot of PDT. I've done a lot of PDT for cancer using this device and then putting ALA down those channels. Same thing. I'll laze a little bit and then get that ALA down there as quick as possible within 2 minutes. Yeah, it's a great question. I think it's such an interesting topic. Yeah. Anything else? Thanks for coming, everybody. Yeah. Yeah.